And now I have the honor to present Professor Hassan El-Maghraby, Professor of Obstetric and Gynecology, Alexandria University, and he is the EFRE President, the head of the board, and the General Director at Shadby Hospital from 210 up to 112, Chairman of the Department of Obstetric and Gynecology from 2015, Director of the Shadby University Hospital Center of Excellence for the ART and the endoscopy since 2009 up to 2012. It's our honor, Professor Hassan, and you can start your presentation.
Thank you very much, Professor Alia, for this kind introduction. It is an honor for me to be associated with endocrinologists, professors of endocrinology. I always respect endocrinology, and I consider it's a very important branch of medicine that needs real work and excellence. And I feel it's not my role to talk about hypothyroidism in front of you and in front of Professor Tamer, but I will do that. I will do that. So I will talk about hypothyroidism from a reproductive perspective. So female infertility affects about 48 million women all over the world, and women are more likely than men to have thyroid disorder. And 1 in 8 women will develop thyroid problems during lifetime. So it is an important issue. The prevalence of hypothyroidism is 2 to 4% in women in the reproductive age. And subclinical hypothyroidism is present in 4 to 8% in women of reproductive age. So this is an important issue and aspect. In this area of medicine, we are witnessing a paradigm shift. We are witnessing the change from one size fits all to personalized medicine. We are shifted from one size fits all through passing through evidence-based medicine up to precision medicine. And precision medicine entails individualizing treatment to patients. You know the patient criteria, and you individualize the treatment accordingly, whether it is thyroxine or anti-thyroxine or whatever. So is thyroid important for reproduction? Yes, it is important for reproduction. How? Direct and indirect. Direct because TSH and its receptor, as well as thyroid hormone receptors, are present on ovarian surface and in oocytes. So this is one. Second, in animal models, thyroid hormones synergize with FSH, and also it induces differentiation of LH receptors, and it changes or alter steroid hormone enzymes. The indirect evidence, it alters GnRH pulsatility. A known fact, it changes prolactin secretion, it changes 6-hormone binding globulin, and it changes coagulation factor. So GnRH pulse control, FSH and LH dynamics are changed. Steroid hormone metabolism, 6-hormone binding globulin, increased prolactin, effects in hemostasis, and methyl tetrahydrofolate gene mutations and modulation of uterine antioxidants. So this is the importance of thyroxine for reproduction in general. We have subclinical and overt hypothyroidism. What are the relation to female infertility? As regards overt hypothyroidism, the most important is that testosterone is decreased and estradiol increases. and LH surge is blunted. Because TRH is increased, prolactin is increased and impairs pulsatile secretion of GnRH, and it induces anovulation. And this is, of course, associated with low progesterone. Overt hypothyroidism induces oligomenorrhea and hypomenorrhea in 25% of women. As regards subclinical hypothyroidism, the association of subclinical hypothyroidism with infertility is not consistent in literature. This can be partly explained by the major issue, which is the variation in cutoff for TSH. So you will find some literature indicating that it should be 2.5, some 3.7, some 4.5, some 5. So the variation in TSH, which is considered a diagnostic criteria for subclinical hypothyroidism, is the major reason why we cannot derive a conclusion from most of the study. So in a large retrospective cross-section study in 11,000 women in Denmark, impaired fertility was associated with subclinical hypothyroidism as defined by TSH more than 3.7. Thyroid autoimmunity is the most frequent autoimmune disorder in women of childbearing age. And the prevalence of thyroid autoimmunity is generally estimated to be around 10% and has been shown to be more common in women seeking treatment for infertility. In general, increased level of antibodies have been defined as the most sensitive marker of thyroid autoimmunity. Therefore, most studies investigating the prevalence of thyroid autoimmunity need sometimes to measure thyroid antibodies. Other causes of infertility have also been linked to thyroid autoimmunity: polycystic ovarian disease, endometriosis. And since late 1990, several studies have been published on the impact of thyroid autoimmunity on the outcome after assisted reproduction. Assisted reproduction is IVF and ICSI. The outcome of these studies, however, are conflicting, probably due to different study designs, small number of enrolled patients, and low absolute number of events analyzed, and the use of other endpoints. So a study comparing IVF outcome in autoimmune thyroid patient revealed that in positive patient, there was a significant less fertilization, less implantation, and less pregnancy rate. The actual difference in number of miscarriage between euthyroid women and women with thyroid autoimmunity undergoing an IVF and control remained small. So, however, the number of oocytes retrieved, fertilization, pregnancy rate did not seem to be affected in thyroid autoimmunity. When you look at all the study, the meta-analyses and the randomized controlled trials that have been dealing with thyroid autoimmunity and assisted reproduction, you will find that there is no solid conclusion. Some of them showed lower live birth rate. Some of them showed no effect, as you can see in this table. As regards levothyroxine treatment and ART, first, overt hypothyroidism, detailed information regarding the effect of hypothyroidism in controlled ovarian hyperestimation on IVF is important. So detailed information about the effect of hypothyroidism and controlled ovarian hyperestimation IVF outcome is limited since no randomized controlled trials are available. It is likely that we will never have data because it is unethical to stop treatment for women who are overt hypothyroidism. So it is unlikely that this situation will be corrected. However, some women with treated hypothyroidism still fail to conceive and seek infertility treatment, including controlled ovarian hyperstimulation. And the latest ATA guidelines recommended to target TSH concentration below 2.5. So this is an area which is very problematic. Should you consider TSH of 5 or 4 or 3? But the outlet is you have to bring TSH to 2.5. You have to bring TSH to below 2.5. Whatever the TSH that you consider is abnormal. As regards subclinical hypothyroidism, a meta-analysis of 3 randomized controlled trials showed some beneficial effect of levothyroxine treatment on pregnancy after ART in women with subclinical hypothyroidism. Although no benefit was shown in regard to clinical pregnancy rates, there was an increase in delivery rates in this study. Personalized medicine means algorithm that depends on patient and investigation. So this is one good algorithm for treatment of women with infertility related to thyroid deficiency. So if TSH is more than 4, start levothyroxine 6 weeks prior to ovarian hyperstimulation or ART, and follow up with thyroid function every 4 weeks. If TSH is 3 to 4, do antibodies. If they are positive, follow up thyroid function every 4 weeks. If thyroid TSH is less than 3, then do T4 and T3 and check TSH after. And if T4 and T3 are increased, treat with anti-thyroid drugs. So in summary, the interaction between thyroid disease and fertility is complex. Overt thyroid dysfunction often leads to menstrual disturbances, fertility problems, and pregnancy complications, and should therefore be treated accordingly. At present, there is little evidence to advise levothyroxine treatment at TSH levels between 2.5 and 4, considering the possible adverse effect of overtreatment in particular patients with mild thyroid dysfunction. It is proposed that careful longitudinal studies should be done in order to understand more about hypothyroidism, whether it is subclinical or related to autoimmune disturbance. So the practice point is that non-pregnant reference range be used for the assessment of subclinical hypothyroidism in whom we plan to become pregnant by ART. The use of appropriate reference range should be based on local population and laboratory-specific references. In general, association with adverse fertility outcomes seem to emerge at TSH level above 4 and not 2.5. There is little evidence to advise levothyroxine treatment at TSH levels between 2.5 and 4, and current scientific evidence considers the cutoff value of 4 for TSH as a reasonable intervention level of subclinical hypothyroidism in women with and without autoimmunity and ART. Thank you very much.
Thank you very much, Professor Hassan, for this very nice presentation to the points. And now we are seeking for the questions.
Dr. Hassan, and I have a question of my own. So you mentioned that the guidelines or the evidence suggests that 4 is the appropriate cutoff limit to consider treatment of levothyroxine in infertile women. But in 2015, the American Society of Reproductive Medicine, they issued this guideline I think you have read it. And they have suggested that for people with TSH from 2.5 to 4, especially those with the antibodies, you may consider giving levothyroxine. So in your practice, do you use the 2.5 or the 4?
In my practice, I use a 2.5 if the patient has a history that could be related to subclinical hypothyroidism. But I don't give it to all patients. And in fact, to be honest, I don't know what are the results of what I'm giving.
We all don't know.
Exactly.
We all don't know.
I think,
Satisfies the
Professor, if you may allow me, if you may allow me, overt hypothyroidism should be referred to endocrinologist. If you have a patient with TSH above 2.5, it should be referred to an endocrinologist. If you have a patient with 2.5 and you decided to use this as a cutoff, okay.
This is very nice, Professor Hassan.
I'm saying the truth. It's it is an elusive subject, and it needs experience. It needs people who are working in that field. It doesn't need reproductive endocrinologists like myself, to tell you the truth. And from this moment, because you made me just search for this for a week, I decided I will never touch them without you.